Okay, we will reconvene again. Yes. So, Piotr, are we ready? We are good. Dziękuję. All right. With that, the next person on our list is Dr. John Satterfield. Dr. Satterfield, welcome. Thank you for joining us.
Chairman Anwar, Chairwoman McCarthy Vahey, members of the Public Health Committee, thank you for the opportunity to testify tonight. I've been a practicing anesthesiologist for 35 years in Connecticut. I'm the past president of the Connecticut State Society of Anesthesiologists, CSSA, and a long-time resident of Southington. I would respectfully request that you review all the submitted written materials from the members of the CSSA regarding House Bill 5488. But rather than speaking on that bill, I'd like to shift my focus to Senate Bill 1. The membership of my state society is unequivocally supportive of this important legislation. In particular, I'd like to comment on three pertinent sections impacting anesthesiologists and, more importantly, patients across Connecticut. Section 22 addresses prescription drug shortages in our state. For years, practicing anesthesiologists across the nation and in Connecticut have faced shortages of critical intravenous drugs. In 2024, this remains a routine, common occurrence in high acuity healthcare environments such as emergency rooms, ICUs, and operating rooms throughout our state. Excuse me. The CSSA fully supports the efforts to study the incidence of drug shortages and the role that the state can have in alleviating this issue. Section 33. A major focus of our national society, the American Society of Anesthesiologists, is on perioperative brain health. The Healthy Brain Initiative has sent to Senate Bill 1 serves as a critical piece of legislation to ensure patient safety. Patients 65 years of age and older receive 1/3 of all anesthetics in the United States. Up to 70% of those patients are at risk for conditions known as postoperative delirium or postoperative cognitive decline. The efforts in Connecticut will be most helpful towards the goal of eliminating these devastating complications. And finally, Section 29 addresses coronary calcium scoring. Representative Exum's testimony was powerful and compelling. Postoperative myocardial infarction is the primary cause of patient death after surgery. Thus, evaluating cardiac risk is critical in the effort to provide safe anesthesia care. Coronary calcium scoring is recognized as a valuable tool to assess the risk of unrecognized cardiac disease, and the CSSA applauds the efforts of the Public Health Committee to make this tool available to patients and their healthcare providers. Thank you very much. I'm happy to answer any questions.
Thank you so much, Dr. Satterfield, for being here physically and in person with us for this conversation. And thank you for identifying some of the areas. There's a lot of love in this bill and thought process that has gone into putting some of these things together. And thank you for your willingness to have a conversation with me about the shortage of medications. I think that's going to be something that's going to become very real. And your specialty is the first one that's seeing this. If you can expand on this a little bit, that the fact that the most basic, well-known medicines that have been there for 30, 40 years are now not available at all.
Senator Anwar, just for example, for the committee, one of the drugs commonly that you're familiar with is epinephrine. That drug is a drug we use frequently in the operating room as well as in the ICUs and emergency rooms across Connecticut. That's just one example of an intravenous drug, but we've experienced many other shortages of what we consider in the broad class of drugs known as vasoactive drugs. drugs that increase heart rate and blood pressure. So epinephrine is one of those. Another is phenylephrine, a drug used daily in operating rooms. And also another drug called norepinephrine, a cousin of epinephrine. Those are just three examples, but to further that, we have experienced significant intravenous opioid shortages to the point that we've had to address our care management protocols. So there have been times when fentanyl has been a drug that's been unavailable or in very limited supply to us, and then other opioids such as hydromorphone, Demerol, and all those drugs are used for specific patients for specific reasons. And when they're not available, it tremendously impacts our ability to provide optimal care. So to be able to address drug shortages in our state, I think is imperative for patient well-being. We've had multiple discussions with Senator Blumenthal trying to address this on a federal issue, but the society's membership is very encouraged by the fact that the state and the Public Health Committee in particular recognizes this is an issue. It affects patient care, and we really appreciate your effort to try to address this locally, and we're very supportive of that effort.
Thank you. And the rationale for us as a state to take this on is that it's going to be easier. We'll probably hear from somebody that, oh, this is a federal issue. But the reality is the federal government waits for the state to try and jump in and start to look at what solutions we can make. And then suddenly it becomes a federal bill. And so hopefully if we as a state can start to look at this, because it's really impacting the well-being of our citizens and their ability to get care in a timely fashion, we are hoping that we'll start to have these conversations, which are going to give us some insight into identifying solutions going forward. And then sometimes the states are a little bit more nimble and able to identify solutions faster than the federal government would. So we are hoping with your help and others that we should be able to look into this further.
We would love to be able to be of assistance in this process. And I'd just like to make one other comment to the committee in general. And I'd like to express my sincere gratitude to all of you. It's been a long day, and for many years, there have been some disappointments and discouragement in my healthcare career. And today gives me a lot of hope for the patients in Connecticut, because I see all of you willing to listen, try to understand the issues and do the right thing for the right reasons for the patients in Connecticut. I'm very encouraged by what I've seen today and the commitment of this committee. And for that, I'm very, very grateful.
Thank you so much. Wow. Thank you. Thank you. Did you bring some medicines with you?
No.
Okay. Okay. Thank you. All right, we move to the next person on our list, which is Dr. Dante Brittis. Welcome.
Hello there. Do you have me? Am I audible?
Yes, you are, but your camera is not in the right position. If you want to move there you are.
How's that?
I can see you now. Thank you.
Good. Senator Anwar, Representative McCarthy and Fallatt, and members of the Public Health Committee. Thank you for allowing me to speak on behalf of the 240 orthopedic surgeons in the Connecticut Orthopedic Society on SB 440 and HB 5316. And let me as well thank all of you for your dedication and staying well into the night on what I'm sure is a time when everyone would rather be home. So thank you. My name is Dante Brittis. I'm a practicing orthopedist. I'm president of the Connecticut Orthopedic Society. The orthopedic community appreciates the committee's review of our antiquated CON process. We've provided written testimony that I'd like to supplement today with an on-the-ground view. The Connecticut Orthopedic Society has long advocated for Connecticut to be serious about providing affordable, quality health care. We should be looking to expand access and not limit. SB 440 offers subtle improvement to the CON process by addressing timeliness. It does not, however, address the #1 hurdle, outdated guidelines that are the foundation of CON determination denials. Ambulatory surgical centers are a perfect example. Owned and operated by surgeons, they provide cutting-edge care at a 40 to 60% discount to the care cost of hospitals. Same cases. Nationwide, they've been embraced by the federal government, expanding yearly the scope of cases appropriate. Connecticut CON guidelines are outdated and provide a large hurdle for new centers in our state. In addition, the process is also impeded by public comment by hospital systems that paradoxically, again, provide care at a much higher cost. With a more user-friendly CON process, the Connecticut Orthopedic Society aims to further support ASC growth by developing a series of Medicaid pilots. With legislative support, we are sure there is significant savings for the state while expanding access for our most needy patients. Meanwhile, HB 5316 offers additional burden to physicians by requiring practice to submit annual reports. By also requiring a CON determination for ownership transfer at the group level, the bill imposes an administrative burden on practices today already encumbered by hospital system pressures, decreased reimbursements, and significant inflationary pressures. Private equity is today's bad boy as it relates to hospitals. Recognize that private equity can also provide a capital source that counterbalances the market forces that threaten independent physicians. This has been stated beautifully all evening. There is no evidence nationally that private equity involvement at the doctor group level adversely affects patient care. Since 2021, 12 states have streamlined or eliminated the CON process in medicine. The FTC has expressed concern that CON laws fail to control healthcare costs. The Connecticut Orthopedic Society looks forward to working with you to bring Connecticut the best, the safest, the cost-effective care by modifying and updating our current CON laws and hoping to present the current bills in a more favorable light. Thank you. Happy
Thank
to
you.
answer any questions.
Sure. Thank you so much for your testimony. I don't see any questions, but we appreciate you coming in and waiting to share your perspective. We appreciate that. Thank you.
I thought that the questions that were asked previously with the rheumatologist were very appropriate, and he did a great job of explaining them. So I'm happy to talk to anybody offline if they'd like as well.
Yes, maybe I can follow up. I was just talking to my colleague. There's a trend that some of the physician groups at this time seem like they like private equity, and I'm having mixed feelings when I hear that.
So I think right now the market is so disadvantageous for the private practitioner and the group private practitioner that private equity offers a, how shall we say, a cleaner road. The alternatives, private practice is significantly threatened. Our reimbursements are down. Hospital systems have a much more advantageous insurance relationship that lets them enforce basically their will on private practitioners. And in fact, when they don't get their way, they actually look to insert their own practitioners into the private community, thereby exposing the private community to higher rates and facility fees that in a private practice, we don't have any wish to do. So private equity, by giving us some capital so we can bring in new physicians, that we can expand services, gives us a mechanism to do that. The cost savings are significant.
But it's not sustainable because Medicare is decreasing. The Medicaid in the state of Connecticut does not pay, and Medicare is not paying enough either. And the commercial has a very difficult process. So the private equity sooner or later is going to recognize that it's not a money-making business for them. So that's the part that I'm worried about, that, and I use the term, there's a honeymoon period everybody's having with private equity, but it's going to not last. Well,
I mean, your points are very well taken. And Medicaid reform, I testified on last week, is crucial in our state. 30% of the citizenship does not have adequate health care. It's underfunded significantly. It's a travesty in our state where we're the second or third most valuable state in the union, And in fact, we have 30% of the citizenship has a medical insurance that's not viable. At the federal level, we went to Washington last year in September and testified to multiple legislatures about the concept of Medicare reform. Medicare reimbursements are down 20%. Physicians need partners to be able to grow. Growth is important. And right now, private equity is a viable option, unless we are all going to be sucked up and work for the hospitals.
So yeah, that's probably another conversation to have, is to figure out that either larger institutions buy the smaller practices, or the insurance industry, which unfortunately is allowed to do so in Connecticut, and they buy the practices, or the private equity comes, because you cannot survive on your own any longer. So
if you want to see costs go up, let hospitals run as a monopoly, or let Optum or one of these big insurance companies run the deal. Then you're going to see costs go through the roof, and you're going to see patient care suffer.
thank you. This is very helpful. I'm so glad you stayed to testify. We appreciate your testimony, and thank you for your insight.
Thank you. Appreciate it.
And next is Dr. Rocco Orlando. Good evening. Good evening, Dr. Orlando. How are you?
I'm great, and good to see you also. Senator Anwar, Representative McCarthy-Vahey, distinguished members, let me admire you for your fortitude on this long day, and thanks for the opportunity to testify. So I'm Rocco Orlando. I'm a practicing surgeon in Hartford for 40 years, and I serve as Hartford Healthcare's Chief Academic Officer. And in that role, I'm responsible for leading our many university partnerships, and particularly our close collaboration with UConn and Quinnipiac University Schools of Medicine. And so that we are a key partner in the training of medical students, residents, and fellows. I also am a professor of surgery at UConn. Today, I'm going to comment on two sections of Senate Bill 1, sections 10 through 8, that call for the creation of a graduate physician role in Connecticut. And then just some very brief comments on sections 24, 25 that propose some additional regulations around board certification for physicians. So first, on sections 10 through 18, the graduate physician role. So the concerns of the legislature about the physician shortages, particularly in primary care, are well-founded and completely appropriate as we in Connecticut struggle to find sufficient primary care docs to meet the needs of all of our communities. And we agree with that assessment. With our medical school partners at Hartford Healthcare, we are working hard and are creating new residency training programs in shortage specialties. So we have dramatically grown the number of residents that we are training with both UConn and with Quinnipiac. And we're particularly proud of new programs that are now coming into being in family medicine and psychiatry. And so that is where we have really been placing our major efforts. I do think that it may be premature to actually consider creating this new role for a new category of physician practice at this point. Now, as previous testimony has commented, several other states, notably Tennessee and 8 or 9 other states, are experimenting with similar pathways. But I would advise great caution in the interest of patient safety and medical care quality at this point. The simple fact is that graduating from a school accredited either by the Liaison Committee of Medical Education, the Commission on Osteopathic College Accreditation, or a medical school listed in the World Directory of Medical Schools, and passing a licensing exam is really insufficient to assure clinical competence, given the variability of some of that training. Current Connecticut statute requires 2 years of training post-medical school to attain a license to practice medicine. Board certification is considered, or board eligibility is considered the gold standard for clinical quality of care, and requires 3 to 7 years of post-medical school training, depending on the specialty. And as drafted, the responsibility for assuring the quality of care would rest entirely upon the supervising physician. We also would have no assurance that the supervising physician would have the skills and aptitude to serve as a medical educator. Certainly something that in our partnerships with our universities, our schools of medicine in Connecticut, faculty development and training and adherence to principles of sound education is really essential to what we're all doing. In addition, we think that there would be additional liability assumed by the supervising physician because of the potential for an uncertain skill set. So I think because the documentation and assurance of clinical competence might be insufficient at Hartford Healthcare with a large physician network, we would not use this mechanism. We would also not anticipate changing our medical staff credentials policy that would allow practice by this category. And a related factor is that we are using our capacity to train young physicians to really, with our medical school partners, to train not just medical students and residents, but also physicians assistants and nurse practitioners who would really all occupy that same learning spot which the graduate physicians would occupy.
Excuse me, Dr. Orlando, but your time is up.
Thank you. I will close by saying we think that it would be worthwhile to, rather than adopting this change, to simply study the situation and observe what's going on in some of the other states. My written testimony, comments on the board certification requirements. So I'll stop here to see if there are any questions.
Sure. Thank you so much. I do have quite a few questions. I will just go forward with my questions. First of all, how much study do you think is reasonable?
So this is I think it depends upon the goal. An earlier speaker really commented that this could be a path to getting a residency position. The problem with the residency positions is that still is the pathway to ultimate licensure and ability to practice independently. And there are simply not enough residency slots funded by the federal government. For years, there have been attempts in Congress to address this by increasing the number of slots, which has effectively been capped by the Balanced Budget Act of 1996. So in this case, with all respect, this is something that where federal legislation is absolutely required.
So let's talk a little bit about this. The answer to my question was that Missouri was the first state that did this or made this law 10 years ago. And in the last 10 years, they've had no issues and it's gone very well. And since that time, about 15 states have moved in this direction. So actually, there are Arkansas, Kansas, Arizona, Utah, Washington State, Louisiana, Idaho, Tennessee. They've moved in this direction. And I'm getting a little concerned because at one point you're saying that you're part of the medical education, but then you're not even trusting the medical students that you're training to be able to do that, because the medical students, by the time they're done, they have 4,000 hours of clinical training in the last 2 years. So, and that's in institutions like Hartford Hospital where they're getting this training. If you look at the American Association of American Medical Colleges, they are projecting a shortage because there's a primary care physician shortage of 48,000 by the year 2034. And in order to get and address this shortage, this is one path for individuals who are not going to be able to match, not because of their qualities, but because there are not enough residency programs. And as a result, we are basically saying, and I wrote an op-ed on this topic as well, that we have in the state of Connecticut, Hartford-born individual who has a medical degree, did not get a residency because was not able to take the boards because of financial reasons, and is working as a security guard or other jobs for the past 20 years. So what we're saying is that the medical students with an average debt of $250,000, if they don't find a residency, which about 4,000 of them in the United States are not finding it because of the number of programs have been decreased, we are asking them to flip burgers rather than work in a doctor's office to be able to get some experience and to be able to get more letters and support and be able to get into a residency program. So I'm a little surprised, Dr. Orlando, about your thoughts on not giving a path to the very students that we are training right here in Connecticut to have a hope for their lives. And if they don't get a residency, and I'm sure you have seen in your 40 years of experience, when a medical student does not get a residency, it's almost like a death sentence for them. And we
Oh.
can't afford that to happen.
So
One-
match day in Connecticut was just on Friday. And all three medical schools in Connecticut, the entire graduating class is matched. And so in our Connecticut medical schools, they indeed all did find residency positions. The enrollment at the American medical schools has increased without corresponding increase in residency positions, and that's really why we're in this in the jam that we're in. And I'm suggesting that the better solution is to increase the number of residency training positions. The path that is suggested with graduate positions will not result in graduate physicians being board certified, and it also means that they will have to secure a residency. There is still an insufficient number of residency slots in the United States. And so this kicks the can on that by giving them something that they can do for a couple of years, but doesn't ultimately solve the real problem.
I know, but waiting for the federal government to act on it will be another 50 years before we'll have this conversation. So I think there's a reality that we have to address, right? Waiting for the federal government is not one of those options, like many of the other things. So I think we have to intervene to be able to start to do something that is other states have started to work on, and they're getting good results. They're getting their primary care doctors, they're getting their psychiatrists, they're getting some of the individuals who are able to work on this. These children, these young boys and girls, they have $250,000 debt on an average. And just waiting and telling them, hey, wait for the federal government is not an option. That's how I look at this.
I guess I'm not sure that I see that that this pathway really gets them. Again, you mentioned psychiatry gets them to clinical competence in a specialty that requires several years of additional training.
Well, there are 2 years that they will be able to get, and hopefully be able to get some experience enough to be able to get into residency, perhaps get some publications, but also more importantly, be able to survive rather than doing odd jobs. And by the way, of all the healthcare workers that are working in the state of Connecticut or anywhere, the medical students, for the number of hours and the number of didactic training that they have, is far more than anybody else. Just so that you're aware, I'm sure you are.
Absolutely.
So condemning them for nothing is not an option. And on the maintenance of certification, there are 9 out of 10 physicians have asked about the mock to be taken away. The board that is doing this has $63 million that they've made. They're having people go through these boards every 3 months and 4 months. This is something that no other profession does to themselves, that you have to take a board every 3 or 4 months, stop taking care of patients, stop doing everything, and then start to sit and take a board. It's a money grab that 22 or so other states have already stopped, and multiple other ones are working on. So I would have you reconsider that option too, if you would. Thank you for your testimony.
Thank you.
Representative Tersiak has a question. Go ahead.
Thank you very much, Mr. Chairman, Dr. Chairman. And hello, Rocco. It's good to see you again.
Good to see you.
Thank you. I'm very sensitive and pretty much agree with what Dr. Anwar had to say, but I did want to stop and say hello so that my wife wouldn't criticize me for not doing it. She says she has great respect for you and says you're the real deal. I tend to agree with her. I suspect we can come to some agreement where Dr. Anwar will get his way, as it should be with the chair. Thank you very much for staying up and spending so much time waiting to speak to us. We appreciate you being here. Thank you. Thank you very much, Mr. Chair.
Thank you. Seeing no other questions or comments, we'll move to the next person on the list, which is Dr. Alan Kay. Welcome.
Thank you. Boy, I thought I was the real deal. But Rocco was a classmate of mine at UConn, and I think he deserves it. So, hi, I'm distinguished leaders and members of the Public Health Committee. My name is Alan Kay. I speak for myself today. I am a physician retired from clinical practice, but still very active on a voluntary basis in our state and in the federal healthcare policy realm. I speak in favor of the general tenor of the provisions in Bills 440 and 5316 with respect to acquisition of group practices. I must caution you, as did Dr. Tong earlier today, that in the case of corporate acquirers, we are dealing with the very smart, creative, and experienced entities who are adept at finding loopholes, which is exactly how we got here today. As such, I would like to address some specific items and differences in the two bills and make some friendly suggestions. There's a significant discrepancy between section 1A3 in lines 86 to 91 in 5316 and lines 7 to 12 in Bill 440. Given my personal knowledge and extensive experience with review of terms in such agreements, the exemption in 440 from oversight if a transfer ownership is to a physician or group of physicians is precisely the most common loophole exploited by corporate takeovers of practices. Of private practices. Bill 5316 does not have such exemptions and specifies the acquiree as any person. If the word person is defined correctly, as I think it is elsewhere in statutes, this can close this tactic for getting around the corporate practice of medicine laws that are present in Connecticut and other states in the country. And that is, there's something called a friendly physician, which is essentially a front for a corporation or other non-physician entity to which the money flows, usually through some contractual relationship, either for billing, management services, financial contributions, capital infusion, rent, or other relationships. Number two, in Bill 5316, lines 257 to 267, there's a new section 1F, which provides for automatic issue of CON through 2025. Why is this in here? Experience has shown that it will cause a flurry of acquisitions to get under the deadline, sometimes hastily conceived and counterproductive in order to be exempt from CON oversight. Also, there's no time limit on implementation once issued. These are not hypothetical. Time will not permit me to recount examples of what happened when CON laws for advanced imaging were made more stringent at some future specified date. Can you imagine the stampede of transactions, including practice acquisitions, that will decimate the private practice of medicine in our state? Given the deep pockets of private equity, and especially given the deep pockets of private equity and other corporate entities. In the beginning of both bills, we defined transfer of ownership in very broad terms. Senator Summers raised some questions about that. That needs to be defined a little bit more clearly and should include evaluation of all financial relationships between affiliates of the acquiring and the acquired entities.
Excuse me, Dr. K, but your time is up. Thank you.
I will sum up by saying, look, I think I've been here since the beginning. The early presenters talked about level playing field. We should have a level playing field. This is not picking on private equity necessarily or corporate entities. Hospital acquisitions, insurance company acquisitions should all be subject to some scrutiny by the state. And certificate of need is one that could be very easily used and seems to be required here. My testimony has changed umpteen times in the 10 hours that we've been here. I would love to answer some questions about this or about anything else having to do with this. I have a lot of experience with it. I was on the private practice work group that met for a year and came out with some recommendations.
Thank you so much for your testimony. So we also are going through some internal journey ourselves. I was going to ask you for a question. I said, tell me about life. What is the meaning of life? You've reached that point right now in this.
Yeah, look, I'm retired. I've been doing this for 30 years, this advocacy. My wife asked me, why are you still doing it? I said, I'm passionate about it. And things are wrong. It's just wrong. If you ask all these physicians that come through that say they support private equity, I have a friend that's a real estate developer. He said there's two types of people in the world, tenants and future tenants. That's what it is with medical practices. There's two types of medical practices. Those that have been acquired or those that are going to be acquired. Unless we do something about it, we're going to be dealing with things like surprise billing that was brought to us by private equity companies and has taken over the country. The whole furor over Medicare Advantage, which was meant to be a way to save money, has shown to be costing money because the people, the smart, talented, creative people have figured out ways to game the system. And that's what's going on here. And we deserve, in this state, to take care of our patients and take care of patients that can't afford it, and even patients who can afford it getting fleeced by taxation and other things. Healthcare is different in that it gets supported by public funds, by taxpayer funds. And what's the biggest payer in the state is probably the state employees union. That creates a lot of costs for us in our state. Our state loses people because of our high taxes. We need to be more responsible and we make the people that provide the healthcare more accountable. My practice was a practice multiple times. I led the practice to become acquired at very high rates. You know what happens? The partners that are in the group get paid out, and we're real happy, and we survive for a few years to get our earnout, and then the people coming in don't get that. And that's not good for recruitment.
We do have a question,
Very
Dr. K.
important.
Hold on a second. My co-chair has a question.
So,
I'll confess it's a quick comment. Dr. K, I just want to say thank you. And thank you for those remarks, which is about the folks who get paid out and then the difficulty in recruitment. And it really does remind me of retirement benefits and pensions and some of the debates that we've had over time and the long-term sustainability. You know, I won't go into the whole pension conversation, but looking at the long-term sustainability of a system, that's what we need to do. It's why we as a group, and you know, I've talked to others about making sure that we are putting those bright minds around a table together to come up with that sustainable solution. And we'll be talking more about that, I suspect. So thank you, Dr. K.
thank you. You did not get a true picture of what happens with practices when private equity gets involved. You did not get a true picture. It's all over the newspapers and the articles and every medical newsletter that has to do with health policy. So I can supply you with the same things I supplied the physician practice work group, and I will make it my point to do so. So you can come to the same conclusion that work group of a broad group of stakeholders, including other private physicians, hospitals, insurance companies, public members of the public and stuff like that. And there's only one conclusion. These things have to be watched.
Thank you so much. Seeing no other questions
Thank
and
you.
comments, we'll move to the next person on our list. You're actually going back to number 77, Sandra Carbonari. Sorry for missing you earlier. I apologize. You're on.
Okay, thank you. So my name is Sandra Carbonari, and I'm a board-certified primary care pediatrician and a member of the executive board of the Connecticut chapter of the American Academy of Pediatrics. And we're in support of Senate Bill 1, specifically Section 19. And this section calls for a group of medical professionals to develop or procure educational material concerning gun safety practices to be provided by primary care providers to patients who are 18 years of age or older during the patient's appointment with such patient's primary care provider. We strongly believe that age-appropriate material concerning gun safety practices should be available to primary care providers for all ages, not just for those over 18 years of age. And including a member of the Connecticut chapter of the American Academy of Pediatrics in the group of medical professionals developing these materials would be extremely valuable, as much of this work has already been done by our colleagues. Education is an important part of improving gun safety. However, as pediatricians, we believe that this education should not be limited to, those only over 18 years of age. Gun violence is not limited to those over 18, and gun violence, as we all know, is a public health epidemic. And it's injuring and killing children at alarming rates. And two of these statistics include the facts that in 2020, firearm-related injuries became the leading cause of death for children and teens aged 1 through 19 years of age. And over 80% of child firearm suicides involved a gun belonging to a family member. The American Academy of Pediatrics has been involved for decades in advocacy efforts to address firearm violence as a public health issue and advance policies that keep children, families, and communities safe. Discussion of firearm safety is recommended in our Bright Futures guidelines, beginning at the prenatal visit and including every well visit through 21 years of age. The AAP has developed resources to provide the counseling and education concerning gun safety, and I have provided links to some of these in my written testimony for you. The mission of the American Academy of Pediatrics is to attain optimal physical, mental, and social health and well-being for all infants, children, adolescents, and young adults. And gun safety is an important part of this mission, and the members of our Connecticut chapter will continue to be strong advocates. We ask that a member of our chapter be included in the group developing or procuring educational material concerning gun safety practices, and that these materials be developed for providers of primary care for all ages. Thank you.
Thank you so much for your testimony, Dr. Carbonari, and thank you for being with us and staying with us through the day and this evening. We have a few people. I will have Representative Radar, Rep. Palm, and Rep. Zupkis after that. Please go ahead, Rep. Radar.
Thank you, Mr. Chair. First of all, Doctor, thank you for being here and bringing this conversation in front of us. I want to ask you a question. So I represent Guilford and a part of Branford. And back several years ago, we lost a wonderful young man named Ethan Song. And we now have Ethan's Law here in Connecticut, and it is focused around gun safety, but specifically safe gun storage. And I'm good friends with Mike and Kristen Song. And when we were having some conversations, I had a really kind of light bulb moment where I wanted to get this knowledge into more household hands, meaning we passed the law, but a lot of people don't even know it exists. And so how could we connect with families of young children to make sure that that knowledge was shared with them in a safe and appropriate way? And it made me think of the annual pediatric physical. And so the concept that I came to arrive at was, why couldn't we share this information through the pediatrician with a caregiver or parent around Ethan's Law and safe gun storage at the annual physical? Just make it another thing that they are given information of every year. And that way you don't miss any families, you don't miss any children, because for most children, they have to have an annual physical to attend school. And, you know, this could be expanded upon. I kind of came from the lens of Ethan's Law, but I wanted to know your thoughts about that. And do you think that practitioners would be open to this? I know it's such a, you know, precious time with their patients on an annual basis, and there's so much they have to cover, but I can't really imagine this not being a priority. But I'd love to get your feedback on that. And if you think this would be something that would, A, be accepted by the pediatric medical community, and how best could that information be delivered?
So I agree with you. And part of, I refer to Bright Futures, and that may not be a term that's that everyone knows. And what those are the guidelines for best practice for what should take place at each well-child visit. And so, you know, children have many visits in the first year, fewer in the second year, and then after that annually. And part of our guidelines that we call anticipatory guidance, the kinds of things you want to make sure you talk to parents about, is gun safety. And so that's already in our best practice. And but as you rightly referred to, there are just seemingly unending list of things that we have to discuss, and the limits on the amount of time we have are getting, you know, shorter and shorter. So it can be problematic. But you know, I know I'm actually retired from active practice now, but when I was practicing, one of my questions was always, are there any guns in the house? And that's a pretty quick question, and it's a, it's a pretty quick answer, yes or no. And then you go on to, yeah, if it's yes, then you want to have that conversation. So I guess in answer to your question, yes, I think this should be something that everyone knows about, and parents should even maybe be asking their pediatricians about it. What can I do? Should I ask? The other important thing is when my child is going to have an overnight or a play date at another person's house, do I, is it okay if I ask, are there guns in your house? And sometimes, having a trusted professional say to them, yeah, that's a really good idea. I think that would be a great thing for you to do. It could save a child's life.
Absolutely.
So we're all about prevention, and yes, we definitely would want to work with you or anybody else who has ideas about how we can really push this forward. And again, that's why I was a little bit dismayed when I first read this, and it said everything about, everything was over 18 years of age. I'm like, whoa, that's kind of late. It really should be even much, much earlier than that.
Thank you. That was my thought around this, and not that it's not important to catch people later on after they're 18.
Oh, sure.
But to your point, I have 4 children. They're all teenagers now. But I don't remember those conversations with my pediatrician, to be honest with you. And if they maybe mentioned it once in the course of several years of that child having a physical. But to your point, if that conversation, do you have guns in the house? Yes. Okay, well, if you do, here's what the law says. And, to keep yourself and your children and children who visit your home safe, this is what you need to do. And it's a 1 minute, and maybe it's a pamphlet, it's something, I don't know. But I'm really encouraged by your input, because you're the kind of experts who have done this their whole lives and know the value of it, but also know the practicality of it, that you can encourage this idea. So thank you so much. I really appreciate it.
And just to add on to what you said, as I know from myself, from caring for my aging parents, that when you do go to the doctor, you probably, you hear it all, you remember less and less as time goes on, and parents go, wow, what was that they said? So to be able to have some kind of physical piece of paper to give a parent would be maybe an important part to include in this, although there would be a fiscal note. I don't think it would be very large, and again, could be an easy way to save lives.
Absolutely. Well, thank you so much for your advocacy. I'm so appreciative that I've been hanging on. I wanted to hear what you had to say, so thank you.
Well, thank you.
Of course.
Thank you, Representative Radar. We have Rep. Palm, followed by Rep. Supkus. Rep. Palm.
Thanks. Doctor, since the Academy of Pediatrics already has this best practice guide, does that mean some pediatricians are in fact voluntarily handing it out? Do you know?
Well, no, this is not, it's not something that's in writing, as far as, something to hand out to a parent. It's, I can show you, I have the book right over here. The book is about this thick, and what you're supposed to cover at every well child visit. So it really is more of a kind of a resource guide for us to think about the kinds of things we want to make sure we discuss.
Okay, thank you for that distinction. So does that mean that some folks are bringing up the topic? Do you have any rough idea of how many would do such a thing voluntarily?
I honestly don't. I like to believe that people are following, best practices as much as possible. But as I said, you cannot, if you took for a particular age group what's in those guidelines, it would probably, a visit would be well over an hour. So obviously we have to kind of pick and choose. Sometimes there is bias, whether it's unconscious or not, that you only ask those questions from people that you think you should ask and don't ask from certain demographics, which again, is one of those unconscious bias things that we really have to learn about and overcome.
Well, I appreciate your advocating for such a protocol. I would, anticipate blowback. There is a very strong rising tide of parental rights that believe on the part of people who believe that their philosophies supersede what is best for the child. And as somebody who trusts teachers and doctors to make those decisions in concert with parents, I just wish you all the best. And if we do end up requiring this, I think we all need to be prepared for standing by our medical professionals when they get blamed and attacked on ideological bases. But thank you. Here's hoping for the best. Thank you, Dr. Anwar.
Thank you. Rep. Zupkus.
Thank you, Mr. Chair. Hi, Sandy. Nice to see you.
Hi, I don't see you, but hi.
Okay, congratulations
Where
on
are
your
you?
retirement. You just answered my question. I was going to ask.
There you are. Hi.
Yeah, hi. Where that information was. I thought you were giving. I misunderstood. I thought y'all were giving something out, and I was just
No. So that's what I'm hoping this bill can do is help produce something that's Connecticut specific that would be again appropriate for whatever age group that you're giving the advice to. And just like anything else, parents can take our advice or not take our advice, but I personally believe that we as pediatricians, especially primary care pediatricians, really need to be the ones on the forefront of and we always have been, of prevention. I would much rather prevent something than to hear people talk about, our hopes and prayers are with you.
Right.
And
yeah. Because I do know there is some curriculum out there, and even for like little kids, kindergarten, this is what a bullet looks like. Don't touch it. If you ever see it, go tell an adult or something. So I would agree there are some things out there, but I just really wanted to say hi and congratulations.
Thank you.
Rep. Carpino, followed by Representative Wielander. Rep. Carpino.
Thank you, Mr. Chairman. Doctor, thank you for staying with us. I'm biased because we love our pediatricians. So I just have a question. Our pediatrician asks, my kids still have their annual physicals. They're young enough. So we're there far more orphan than that most years. But she asks about whether or not there are firearms in the home already during annual physicals. Is that unique to her?
I hope not. But one of the reasons why I decided to speak about this bill is that this is the bright futures and all these things are members of the American Academy of Pediatrics and our Connecticut chapter are knowledgeable about it and are, sent information, et cetera, about it. But not all providers of care for kids are members of the, members of our academy. They may be pediatricians, they may be family practice providers, they may be APRNs. I think that it's important that everyone knows about the best practice of how to approach this. And I'm really happy to hear that your pediatrician always did. I did, but again, I can't speak for everybody else.
No, and thank you. And then that's why my question was sincere, because we do get asked during our physical, and I shouldn't assume, but we've been with her long enough. I suspect if we said yes, there would be some counseling or some education at that point. It would be very appropriate at that point. So I was just kind of surprised that not all pediatricians or physicians doing physicals of minors are doing that. So thank you for clarifying. I appreciate your patience with my question at this hour.
Sure. No problem. Thank you.
Thank you. Thank you. And I have Representative Wielander who has a question or comment.
Thank you, Mr. Chair, and I'll be quick. I just sort of to echo what one of my good colleague just mentioned. We also had a pediatrician who regularly asks our child, us, and when we go in for our pediatric appointments, are there any firearms in the home? And then when we do answer yes, the follow-up question is always, are they safely stored? Do you have any questions about safe storage? Do you need any assistance with that? Since this is already best practices, and I know that repetition is always helpful when normalizing certain conversations, such as, are there firearms in a home before a play date, or getting together with other families? Do you think that potentially, instead of the medical route, that for under the age of 18, the best way to maybe approach this would be through a school system conversation, in your opinion?
I think that would be a good adjunct. The reason why I think it needs to go through the parent with some trusted professional is that a child may learn that, about not touching guns, et cetera. But, kids are impulsive. They don't always, they know what's right and wrong, but they don't always act on it. And with peer pressure, et cetera. And it is it's the responsibility of the parent to get that gun safe, get those gun locks, put the ammunition separately from the guns, on all those kinds of things. So I think both together would be true. I think that's a great idea. But I think there needs to be some resource that's a trusted resource for the parent also.
I agree. I think always having trusted sources of information and being able to ask questions, without any judgment is always really, really important for ensuring the safety that we are all hoping is the outcome. So thank you very much for your time. And thank you, Mr. Chair, for the time asking question.
Thank you so much. Thank you, Dr. Carbonari. You've been amazing. We appreciate you.
Thank you.
If my children were not older, I would have actually asked for your address. With that, we'll move to the next person on our list, which is Mark Thompson. Welcome, Mr. Thompson. Thank you for your patience with us today.
Thank you so much. Honorable Senator Anwar, Representative McCarthy-Vahey, and members of the Public Health Committee. My name is Mark Thompson, and I'm the Executive Director for the Fairfield County Medical Association. FCMA represents over 1,000 physicians in all medical specialties. While our organization is generally supportive of SB 1 in its entirety, I will limit my comments to 3 sections. First is Section 10, that would allow recent medical graduates who have yet to complete a postgraduate medical residency program to work under the direct supervision of a physician if certain conditions are met. While Section 10, as currently written, may be cumbersome and difficult to implement, we wholeheartedly support the notion of creating, in essence, an apprenticeship-type program for recent graduates who would like to gain hands-on medical experience as they await acceptance to a residency program. This makes sense when one considers that medical graduates have more classroom training than advanced practice registered nurses and physician assistants. These medical graduates are a growing, untapped source of labor for those medical practices that are experiencing an acute shortage of medical expertise. Next is Section 24 that would prohibit the use of board certification and maintenance of certification as a criterion for hospital medical staff privileges and participation on a physician provider panel of an insurance company, health insurance company. When the specialty boards were created, they were never intended to be used as a credentialing tool, but that is exactly what has happened over the years. The state of Connecticut mandates physicians receive no less than 50 hours of continued medical education every 2 years, some of which is prescribed in very specific areas. Yet the state does not require boards or MOC for medical licensure. Good physicians are being blocked from practicing, and boards alone should not be a deciding component for privileges. Last is Section 28 that would align the state statute with the Federal National Labor Relations Act as far as allowing certain employed physicians the right to participate in a union. Nurses and many other healthcare professionals already have the right to be represented by a labor organization, and physicians should have the same ability. Clarifying the right of employed physicians to be represented by a union is important when, by some estimates, and depending on where you are in Connecticut, approximately 80% of the physician workforce is employed by a non-owned physician entity. As a result of the ever-growing demographic of employed physicians, serious consideration should be given to strengthening the voice of employed physicians for the betterment of patient care. This section is much needed and it should be passed. Thank you for your time. We would welcome the opportunity to work with you on all of these topics.
Thank you, Mr. Thompson, for taking the time to look at all aspects of the bill and the relevance. And I take it this is the position that you're speaking of on behalf of your membership as well, right?
That is correct.
Okay, this is very helpful and encouraging because these bills are focused on providing some workforce challenges that we are addressing, and I think your organization is trying to address as well. So I wanted to thank you for your testimony, and I do not have any questions, but I appreciate you staying with us till this time. With that, we'll move to the next person on our list.
Thank you so much.
Thank you. The next person on our list is Mary Jo Archambault. Welcome.
Thank you. Good evening, distinguished leaders and members of the Public Health Committee. Thank you for allowing me to submit testimony this evening. I am a resident of Windsor Locks, Connecticut, and am a full-time faculty member at Southern Connecticut State University. I am testifying today for the inclusion of certified therapeutic recreation specialists in the working group for Public Bill 1, Section 36, to address the pervasive issue of social isolation and loneliness. As a certified therapeutic recreation specialist with 25 years of experience in the field, I offer insights into the invaluable contributions that recreational therapists can make to combat this pressing societal challenge. Recreational therapy addresses the 5 domains of health. Our profession uses recreational activities to enhance the social, emotional, cognitive, spiritual, and physical functioning of individuals. These domains are not separate entities, but are interdependent upon each other, meaning one cannot simply address social isolation without examining the other domains. Recreational therapy aims to improve the overall well-being and quality of life of participants by encouraging them to engage in purposeful and enjoyable activities that foster social interaction, build relationships, and strengthen support systems. Recreational therapists are equipped with specialized skills and knowledge, which play a pivotal role in mitigating social isolation through person-centered treatment approaches. Our profession is dedicated to fostering social connections and improving the quality of life for individuals experiencing isolation. We also have the skill set to teach communication skills, interpersonal skills, reciprocal relationship skills, and increasing social confidence. Furthermore, recreational therapists work with our most vulnerable populations, older adults, individuals in psychiatric facilities and physical rehabilitation facilities, individuals with developmental disabilities, and veterans. As educators in the state university system, my colleagues and I are preparing our students in recreational therapy to address issues such as loneliness and social isolation. Considering the profound impact of social isolation on individuals' well-being, it is imperative that certified therapeutic recreation specialists be included as members of the working group for Public Bill 1, Section 36. Our expertise, experience, and dedication uniquely position us to contribute valuable insights and strategies to combat the loneliness epidemic and promote social connection. Thank you for your attention to this important matter. At this time, does anyone have any questions?
Thank you so much for your testimony tonight and for spending your time here with us and for your interest in such an important issue. We heard from another person who had the same suggestion earlier, and we hear you and acknowledge you.
Thank you so much.
And seeing no other questions or comments, we wanted to thank you for being here with us and appreciate your testimony. Next on our list is number 88, Meg Morelli. Welcome.
Thank you, Senator Anwar. I'm Representative McCarthy Vahey and members of the Public Health Committee. My name is Meg Morelli, and I'm the president of Leading Age Connecticut. Leading Age Connecticut is a statewide membership association representing not-for-profit provider organizations serving older adults across the continuum of aging services, including home health care agencies and hospice agencies. On behalf of Leading Age Connecticut, I'm pleased to testify in two bills before you today regarding healthcare workforce safety, Senate Bill 1 and Senate Bill 369. I would also like to mention that we are part of a coalition of healthcare provider associations that submitted testimony on Senate Bill 1, and specifically the cybersecurity provisions, raising our concerns regarding the statewide health information exchange, better known as CONI. Now, regarding the first two bills, Leading Age Connecticut thanks the committee for raising the issue of workplace violence and healthcare workforce safety in these bills. We offer our assistance to the committee in your effort to aid and support the home healthcare workforce and would be pleased to assist the working group that is proposed in Section 8 of both bills. In fact, we would strongly encourage the establishment of this working group so as to further develop and enhance efforts to address the safety issues that present when providing home and community-based healthcare and aging services and supports. As you know, in 2011, the General Assembly enacted Public Act 11-175, an act concerning workplace violence prevention and response in healthcare settings, to require certain healthcare employers to develop and implement workplace violence prevention and response plans, and to report incidents of workplace violence to local law enforcement. The act also established criminal penalties for assaulting of a healthcare employee. These statutes were later amended in 2015 to require that healthcare employers file an annual report of the number of workplace violence incidents to DPH. The current laws cover healthcare providers with 50 or more employees, including home healthcare and hospice agencies. The bills before you today look to enrich the elements of the workforce safety statutes with regard to the home care and hospice agencies that are licensed by the Department of Public Health. Section 1 of the proposed bill seeks to define the risk assessment portion of the intake process for home health care and home health aid agency clients, and we have some concerns. The intake processes that are currently performed by our member home health agencies utilize many of the elements outlined in this section. It must be understood, however, that the intake process is reliant upon the information that is available and provided at the time of intake. This information may be coming from the referring entity, the client, their family, or others who are directly involved in the procurement of the home health agency services. There are also public information sites that can be accessed, but not all information may be made available on these sites. The intake process also relies on a level of trust. Trust that the information received on intake is true and complete, and trust that the client and those close to them will act as requested with regard to implementing safety measures in the home where the care will be delivered. It is thorough, but it is not a perfect process. We are concerned that Section 1 of the bill reads as though the full responsibility and liability of ensuring the collection and accuracy of all the information listed falls directly and solely on the licensed agency. We ask that the specific contents of a risk assessment not be outlined in statute. But if it is determined that the committee would like to mandate the specific details of a risk assessment, we would ask that this task be assigned to the working group proposed in Section 8 of the bill. We thank the committee for proposing the reinstatement of a Medicaid payment for escorts used for safety purposes and would recommend extending this reimbursement option to other providers who send healthcare staff into the home. And finally, we support the establishment of home care safety, the home care staff safety grant reference in Sections 7 and 9. We thank you for this opportunity to testify on these bills and for your consideration of our opinion, and I'd be happy to answer questions.
Thank you so much, Ms. Morelli, for your testimony. So you do have a written testimony as well?
Yes, I did submit written testimony.
Okay, because I think after 11 hours and 11 minutes, I'm slowing down a little bit, so it will be good to.
Well, thank you for sticking it out.
Of course. Thank you for your testimony. We appreciate your insight. We will take that into consideration.
Thank you very much.
Seeing no other questions or comments, we go to number 89, Jody Cummings. Welcome.
Good evening, Senator Anwar, Representative McCarthy Vahey, Senator Summers, and Representative Claritas Ditria, and other honorable members of the Public Health Committee. My name is Jody Cummings, and I'm here before you today on behalf of the Mashantucket Pequot Tribal Nation. In addition to being General Counsel for MPTN, I'm an enrolled member of the Lumbee Tribe of North Carolina, so I can personally relate to the impacts and importance of state legislation that affects tribal nations here in Connecticut. I'm here today to speak in support of HB 5488 and specifically Section 7 of the bill. Section 7 allows the governor to enter into an agreement with any federally recognized Indian tribe in the state, pursuant to which birth and death certificates issued pursuant to Chapter 93 of the general statutes concerning a birth or death occurring on land held in trust by the United States for a tribe to be filed with and issued by the clerk or registrar of vital statistics of such tribe in lieu of being filed with and issued by the registrar of vital statistics of a town or municipality. Native peoples have continuously occupied southeastern Connecticut for over 10,000 years, including the area that now comprises the Mashantucket Reservation. By the early 17th century, approximately 8,000 Pequots inhabited 250 square miles of this region. However, the Pequot War had a devastating impact on the tribe. By the time it ended, many Pequots had been killed and others were placed in slavery or under the control of other tribes. Those placed under the rule of the Mohegans eventually became known as the Mashantucket Pequots and were given land at Noank in 1651. In 1666, the land in Noank was taken from the tribe and they were instead given back property at Mashantucket. The tribe battled to keep its land while at the same time losing reservation residents to outside forces. The reservation population dwindled. Also, an illegal 1856 land sale reduced the 989-acre reservation to just 213 acres. Over the years, MPTN has prioritized having as many tribal members as possible return home to Mashantucket. In the early 1970s, tribal members began moving back to the reservation, restoring the community, seeking economic self-sufficiency, and revitalizing tribal culture. By the mid-1970s, the tribe had embarked on a series of economic ventures and recovered illegally seized land. With the help of Connecticut's congressional delegation, the Mashantucket Pequot Indian Land Claims Settlement Act was enacted in 1983. That act granted the tribe federal recognition and helped to facilitate the repurchased and federal trust acquisition of lands covered by the act. Currently, Mashantucket Pequot has over 1,000 tribal members and the reservation covers more than 1,600 acres. This abridged version of history conveys the importance of having Mashantucket properly recognized when births and deaths occur on the tribe's lands. The tribe fought hard to keep its land and to be recognized as the sovereign nation that it is. Policies that ignore the status of the reservation as its own jurisdiction and instead treat it merely as another part of a Connecticut municipality must be addressed. Continuing existing practices dismisses who the tribe is and the significance of a distinct homeland that has been maintained for centuries. To be born or to die at Mashantucket and have a certificate that identifies the location as a Connecticut town cuts deeply. HB 5488 will appropriately address that harm. On behalf of the Mashantucket Pequot Tribal Nation, thank you for your continued support and making this important policy proposal a reality.
Thank you so much for your testimony. Mr. Cummings, you had the opportunity to listen to the registrars or of the town that had spoken with their concerns earlier?
I was not present for the testimony, Senator, but I did read the written submission and saw some of the transcript of the exchange that was had during that testimony.
Okay, how would you respond to that?
I would just say, if there are concerns about marriage certificates, we'd be happy to talk about that. I have never heard any concern about that in the past, but if there are concerns, we'd be happy to understand those and try to address those to the best of our ability.
And would the tribes be willing to share the data with the neighboring towns so that they would have some of that information too?
I think it's something that we'd absolutely discuss and want to understand the concerns that they have, and certainly it's a topic that we'd be open to discussing. Yes.
Okay, we thank you for staying with us and your testimony. We appreciate you. Thank you.
Thank you.
Next on our list is Mark Schaefer, and he's not the last person. There's somebody else after that. So go ahead, Mr. Schaefer. Welcome. You need to unmute yourself.
That's 2 out of 2 this session that I've done that. Thank you. So apologies. Can you hear me now?
Very well.
All right. Good evening, Senator Anwar, Senator Vahey McCarthy, Representative Claritas Ditra, Representative Summers, and members of the committee. My name is Mark Schaefer, Vice President, System Innovation and Financing at the Connecticut Hospital Association. We appreciate this opportunity to submit testimony concerning House Bill 5488, an act concerning various revisions to the public health statutes. CHA opposes sections 2, 5, 6, 11, and 12 of this bill. CHA has concerns with section 2, which seeks to penalize providers who fail to report adverse events under 19A 127N, unreported adverse events which occur infrequently. We are puzzled by the need for more punitive measures when there are already effective processes in place to align reporting with the adverse event program requirements. CHA and the Department of Public Health have an existing open and collaborative process to ensure discrepancies in reporting of adverse events are resolved and providers obtain clarity so that the system collects accurate reports. Punitive measures can foster over-reporting, which muddles the system and detracts from the purpose of making care safer. Instead, DPH could increase real-time feedback opportunities so that events meeting reporting criteria are accurately captured. Sections 11 and 12 of this bill focus on the injection and infusion services provided by hospitals in off-campus settings. The majority of this care supports cancer treatment, which typically involves frequent infusion of chemotherapy or other drugs by nurses or other hospital staff under a physician order. Section 12 of the bill would introduce an outright prohibition on commercial reimbursement for these services when provided off campus. Stated another way, hospitals and the clinical staff who support these services would receive no commercial payment whatsoever for providing these services, other than for the cost of the drug. This would likely result in an immediate cessation of such services and the loss of access in clinics across the state. It would also introduce the needless loss of tens of millions in hospital revenue at a time when hospitals across the state are experiencing extraordinary financial challenges. Low-income patients on Medicaid rely on the access provided by hospitals, access which they might not otherwise be afforded in community practice settings. In addition, hospitals often serve patients with more severe or complex conditions that can be effectively managed in non-hospital settings, that cannot be more severe than can be handled in non-hospital settings. There's no public health rationale for making it illegal for hospitals to collect commercial reimbursement for these services, which would result in the elimination of these care settings entirely and access for all patients who rely on this care regardless of payer. Section 5 seeks to remedy a problem where none exists. Currently, law allows the collection of prohibited facility fees if those fees were already included in a contract between a hospital and a commercial health insurance payer. Once a contract reaches its expiration, those prohibited facility fees may not then be collected. Section 5 makes a violation of current law an unfair trade practice despite the lack of evidence over the past 8 years that current law is not being followed. The
Excuse
intent
me,
of section.
Mr. Schaefer, but your time is up. Thank you.
Thank you.
Actually, Mr. Schaefer, if you want to just complete your thought, please.
All right, it's a short one. Thank you. The intent of section 6 is unclear to us. We support the prohibitions regarding medical debt to a credit rating agency, but oppose the attachment of an unfair trade practice violation. It's not exactly clear why this change was being made at this point. So we're interested to learn more about the intent. And that's it. Strongly encourage the committee to strike those particular provisions of the bill. Thank you.
Thank you so much. And you do have a written testimony too, right?
I do.
Thank you. This would be very helpful because I think we are trying to take some notes, but we may not have been able to keep up.
Sure. Happy to take questions if there are any.
Thank you. All right. Seeing no other questions or comments, thank you, Mark. And the last person for the evening to speak today is Diane Lauricella. Welcome.
Oh, thank you so much, Senator Anwar and Representative McCarthy-Vahey, for staying so long and for offering this option, this hybrid option. My name is Diane Lauricella. I live in Norwalk and in Fairfield County. I'll be very brief because I'm the last person, but also you've been there for many hours. I wanted first to say there are so many very important parts of this bill. I'm in support of SB1, and that's what all I'm going to speak about. I apologize for missing my number 58. Life got in the way. And I thank you for letting me speak now. I just wanted to mention my support for section 7, 8, and 9. And I wanted you to consider in section 8, adding an OSHA or a Connecticut or a Connecticut OSHA person on the study committee. I forget the term that you're using. I'm very much, as the person who helped begin the recent improvements for home care, for the need for a home care ombudsman, and one day I hope home hospice ombudsman through my representative, Lucy Dathan, I also wanted to look at the other side of the coin, and that is, of course, making sure that our home health care representatives and workers are protected. I had time throughout the day to listen to some of the testimony about all the reasons, especially with Senator Marks, why there needs to be a better system to protect the home health care nurses and other workers, and a very user-friendly way that they should be notified that does not violate HIPAA, but the workers have rights too. And that needs to be put forth. So I'm so pleased that this is in the legislation. So strengthen added protections and have definitions and consistency. I also just wanted to say that I applaud Section 3 for a Healthy Brain Initiative, Section 36 for a loneliness study group, and actually something that I regret not having the time before your session, and that would be the addition of a new Section 37, believe it or not. And that is the fact that something I'll work on, I guess, for the next session, and that is something I've mentioned before, but have just not had the time, and that is a decision about review of the role of local and district health directors when it comes to their role related to toxic substances and hazardous waste sites and air quality and noise. There are some health districts. I just wanted to maybe plant a seed. The role of the health director is changing, and some towns and cities, they have embraced it, but it is not consistent. There are some that are still in the old model where they call environmental health, looking at septic systems, new wells drilled, and restaurant inspections. We have to explore through a working group the new role of health directors, both local and district or regional health directors. I'm an environmental specialist in toxic waste and waste management, and I have, when I do my work, have been shocked at the difference of ability and knowledge when it comes to groundwater contamination and toxic substances in sites that have never been cleaned up. Most of them have been, but many have not. And there's just not, they're not giving the service that I know. But they have quite, as you know, in the statutes, a health director has amazing power. They don't want to misuse or abuse their power, but because of that power, the public expects them to protect them from toxic fumes, air quality issues, noise, which is a pollution source in a way, and old toxic sites. And I just do not think there is consistency amongst health directors. That's not what I've seen in many. So with that,
Excuse me. Oh,
yeah.
Go ahead.
I just wanted to say thank you for listening. I would love it if you've add section 37. I know that would be tough. I could send something to you with better language. If not, I really think we need to have a working group to study this for the next session at least. Thank you.
Well, thank you so much for your testimony. Seeing no comments or questions, we wanted to thank you for your testimony, and that brings us to a conclusion. I just wanted to thank each and everyone who's been, this is actually going to be the last public hearing for our session, this session, and it's been a pleasure. I wanted to thank everyone who's been here, starting from my co-chair, the ranking members, each and every member who's been part of this, the vice chairs, the CTN, our Public Health Committee team members who have been instrumental. They have worked nonstop throughout the day. So you're all marathon runners, and above and beyond, the people who have come to testify. This is all about you, and we have been here listening to you, taking notes, and reading each and every one of the testimonies. So, my Madam Co-Chair, you're on.
Thank you all. Good night.